Okay, so here is chapter 6. We'll be talking about genetic and developmental disorders. So we'll start with the basic overview of the genetic components. And again, this is just a basic overview. We, of course, have deoxyribonucleic acid, that's DNA. We have ribonucleic acid, that's RNA. We have genes and chromosomes. So DNA is formed from different nitrogenous bases. It comes in the form of purines and pyrimidines. The purines are adenine and guanine, whereas the pyrimidines are cytosine and thymine. And normally they go in a specific order. So there are, again, 4 nitrogenous bases. The adenine can only bind with thymine, and then guanine can only bind with cytosine. So for DNA, those would be your different combinations, and they form things called codons. So codons are a series of 3 of these bases in pairs that forms a genetic code that would then be translated. Now, the difference between DNA and RNA is that RNA replaces thymine. So it does the same thing that DNA does, but except that genetic code reads with adenine, and then instead of thymine, it's actually uracil that would bind to the adenine. And then, of course, the cytosine and the guanine would still bind together. So again, they bind together in groups of 3s. Those are called nucleotide triplets, and then those triplets help form genes and codes. So we have a series of genes and codes that we have throughout the body. I don't expect you to memorize all of the amino acids and their pairs. That's more of a A&P issue. But just know that this is how the body at base level starts to form different codes to produce amino acids, which then help you produce your proteins that are used throughout the body. As mentioned, we have chromosomes, and chromosomes come in the form of double-stranded DNA in the nucleus. And for humans, we have 22 pairs of autosomes. So these are things that are very similar and read genetically throughout the body. And then we have 1 pair of sex chromosomes that, of course, determine the gender of the human. So those autosomes are formed from DNA. And again, DNA is formed from those amino acids and those codons in a specific code. So they go together. We have 22 pairs of those autosomes, which are chromosomes, and then 1 pair of those sex chromosomes that helps determine gender. And again, all of these autosomes, they are similar in function, but they can translate or show up as different genetic variables for humans. So again, these are things that we look for with chromosome 1 or chromosome 23 or what have you. But again, the expression or the way that that individual would then appear, it's based off of what genetic code they particularly have. So again, 22 pairs of autosomes and 1 pair of sex chromosomes. We have 2 different types of cell divisions that we look at in genetics. The first one is mitotic cell division, or otherwise known as mitosis. And one cell results in 2 identical daughter cells, so it replicates itself. And what's supposed to happen is that each cell should contain 23 pairs of chromosomes. This is a diploid matter. So again, it's literally having like identical twins. One cell replicates into something identical, and now it should have the same pairs of chromosomes. This is called a diploid mitotic cell division. And then we have meiotic cell division, and this is more applicable to having sex cell division. So we would look at ovum and sperm when it comes to meiosis or meiotic cell division. So each cell contains 23 single chromosomes. This is different from mitosis, where there's 2 individuals that have both sets or pairs of 23 chromosomes. So the ovum is coming with half of the chromosomes, half of the pair of chromosomes, so it comes with 23. And then the sperm comes with 23. So they are considered haploid, haploid. So what's supposed to happen with meiosis is that they come together and then they would make one cell that should be diploid once they come together. So again, the difference between mitosis and meiosis is that you have one cell on the mitosis side that has everything that it needs. It has both pairs of chromosomes, versus meiosis, you only have half of the chromosomes and it has to bind with something else in order to create the 23 pairs of chromosomes within that cell. So we'll go over a little bit regarding the trait inheritance side of things. So we have genotypes and phenotypes, and again, this is more so over on the meiotic side of things. We have two parents donating half of the chromosomes to create one individual, or maybe two, depending on if you have twins, but one individual that has a full set of chromosomes. It should have a pair of chromosomes, each with 23. So when we look at the genotype, that is one parent's donation and the other parent's donation. In this case, we're talking about the ova and the sperm, and it creates the genetic makeup of an individual. So this is what you have in your traits. You have inherited traits from mom and you have inherited traits from dad. So we don't always see all of the traits we inherit from mom or dad though. So this is just strictly related to your chromosomes and what you have received from each parent. Now, when we talk about phenotype, that is the traits that are absolutely inherited from mom or dad, but they're the ones that are most observable or most apparent. So when you think of phenotype, you could think of the physicality. What can I see that I've inherited from mom versus what can I see that I've inherited from dad? So we like to simulate this, and you may have seen this in your A&P classes, but normally Punnett squares, this is from Mendel's theories of inheritance. Punnett squares help us determine what is a dominant gene and what is a recessive gene. And of course, a dominant gene is the one that's most likely to be expressed from the parent that is dominant in that area, versus a recessive gene is for a parent that is least likely to be expressed. So you may have seen a Punnett square before. We're not necessarily going to do them, but just remember that because we're receiving information or chromosomes from one parent or another, they don't always express themselves as a phenotype because one could be a dominant gene versus the other one being a recessive gene. So here's a general overview of different types of genetic mutations. So again, when we're getting information from parents, or even if there is a replication issue, there are chances to have genetic mutations. So you can see this either on the meiosis side, which is the complete creation of a daughter cell from a single cell, or you can get genetic mutations from donations from different parents. It's very possible. So the first one is deletion. Just part of the chromosome information has been deleted in the process of replication. Then we have duplication. Maybe there's more information added that doesn't need to be there. We have inversion, where there's literally a flipping of the information. Now, granted, it's all still there, but it's not in the correct order that it should be. We have insertion, where maybe this particular part of the genetic code is not supposed to be given to that area of the chromosome, but it has been, and it's caused an insertion. So it's not originally there, not supposed to be there, but here it is now. And then we have translocation, where part of a gene drops down or comes up in an area that is not supposed to be. So again, the genetic information is there, but it's not in the right location. So just look at this photo on the right side, and it kind of gives you an idea of what deletion versus duplication, inversion, insertion, and translocation looks like. And again, these are genetic mutations that can happen from either one side or the other for meiotic issues, or even just in the when they have meiosis and there's a daughter cell created. So just make sure you note those differences. Okay, so we have genetic alterations in human disease. This is just a general overview. As you can see, there's 3 boxes broken down with genes, environment, and chromosomes. As far as genes, that's talking about your autosomal dominant recessive disorders, and then you have sex-linked disorders, and then you have your mitochondrial disorders. The environment can also cause different cancers and disorders. And then we have chromosomal disorders, and that's what we were talking about earlier. With the different alterations in the structure and the format. So that would be kind of like your genetic mutations under there. And then you have the alterations in numbers. So when we talk about the inheritance of polygenic disorders, and that could either be single genetic issues or multiple genetic issues at the chromosome level, we have 6 different areas that we look at. It could be a complex interaction of multiple factors, so it doesn't point to one issue. And then we have where there's a less predictable pattern. We have monosomy, where there is only one chromosome, and that indicates Turner syndrome, and we'll talk a little bit about that in our later slides. We can also have trisomy or disomy. Trisomy is known as Down syndrome. So this is multiple chromosomes in an area that it's not supposed to be. Again, this is defined as multiple areas of chromosome locations that affect the phenotype. So at the genotypic level, the chromosomes are at multiples or singles or whatever the alteration is, and then it shows up as either different diseases or different areas. And then sometimes we just have environmental influences, and I would like to add maybe there's a maternal issue or a paternal issue. So again, there's different reasons why there are polygenic disorders. There are different reasons why you have single chromosomal disorders versus multiple chromosomal disorders. And it's just good to know that sometimes it's a combination of all these things that creates that syndrome. So now we'll talk about chromosomal alterations, and this is dealing with meiotic side. So we're getting a donation from parent to parent to create one cell that hopefully would get the appropriate number of chromosomes. But again, we are talking about an alteration, and one of the most common alterations is called non-disjunction. And all non-disjunction is that there is an unequal number of chromosomes between cells. We have different types. Of course, we have monosomy and trisomy, and we have mosaicism. Mosaicism is the combination of cells with the regular chromosome number, and then there are those with altered chromosome levels. So we actually just see of two of this alteration. So one is normal and then one is not, but you see a combination of those within the area that you're looking at. Then we have monosomy, which is where you're supposed to have 2 pairs. You're supposed to have a pair, one donated from each parent, but you only have one chromosome in that cell. So that's called monosomy, when you're supposed to have 2, but there's only one in that area. And then trisomy is when you are supposed to have 2, but you actually have one extra chromosome. So that is the result of 3, hence trisomy 3. And then we have alterations in chromosome structure. Again, we've talked a little bit about the alterations in chromosome structure, and we can get that translocation where pieces of chromosomes aren't in the appropriate area. They literally transfer to another side of a chromosome when they're not supposed to be there. Here we'll discuss developmental disorders overall, and some of the developmental disorders, or most of them, they're called congenital disorders, so they happen in birth. So there are several reasons why we have congenital disorders, and just understand that this can cause different conditions within the fetus up until birth, and you'll see the expression of what those disorders are. So you do have environmental factors that can include chemicals and hormones. You have organogenesis, where there's a disorder with the organs that are supposed to be developed, and that can happen through the weeks of maturity for that fetus. We have teratogens, and that would actually apply to smoking and alcohol. When someone that is pregnant smokes or ingest an inappropriate amount of alcohol, that is teratogen. So you're damaging the fetus during those developmental stages. You could have maternal infections that will cause these congenital disorders. You have ionizing radiation, which is why you're supposed to stay away from radiation when you're pregnant. And then even maternal nutrition can cause some congenital disorders just by not hydrating or not intaking the appropriate amount. Or it could come from ingesting too much of different vitamins and minerals. So again, it's supposed to be in balance when it comes to nutrition, but sometimes when you don't have balanced diets, this is what the result is. So again, congenital disorders are disorders that happen through the development of a fetus till birth. As far as the management of genetic and developmental disorders, normally you have to have a screening and diagnosis. For maternal issues, you have a prenatal screening and a postnatal screening. And then the treatment strategies is assessing the literacy level of the parents and provide information about the rates of risk. And you also want to promote the ability for those parents to make informed decisions. And again, this is across all congenital disorders and across all genetic disorders. Oftentimes they'll run tests on amniotic fluid. It's called immunocentesis. Sometimes they'll have NIPT tests that help determine if there's a impending genetic disorder. But once they find that there's a potential problem, then they will be able to provide information to the parents about the risk and hopefully be able to cope and manage what the potential disease is. So here's an overview of the different developmental and genetic disorders that we'll discuss today. There are several, and just again, look at the overall picture with these. Of course, there are differences that transcend, but again, these are genetic or developmental disorders that you should pay attention to. So we'll talk about Huntington's disease first. And the first thing you should know about Huntington's is that this is an autosomal dominant disease. So when we talk about autosomal, we're talking about the chromosomes, and generally it is a defect in the chromosome 4, or also known as the Huntington gene. So it is a neurological disorder, but again, it is associated heavily with chromosome 4. So because this is an autosomal dominant disorder, the chromosome that is damaged, or really the allele that is damaged, is why the disease is presenting itself, because it is a dominant gene. So what it does is that it causes the degeneration in the brain, particularly in the basal ganglia, and it causes a variety of clinical manifestations, but normally it manifests with movement and cognitive impairment, as well as emotional impairment. There is some emotional disturbances. You may see some involuntary movements with patients in Huntington's disease. Of course, there's a cognitive impairment, and it's present in all people with the defective gene. So these manifestations you'll see in all of those individuals that have those genes. The diagnostic criteria includes a medical history, physical examination, and then they look at your family history specifically because it is a genetic disorder. So they'll look at the chromosomal makeup of your family members, particularly the paternal and the mother side, to see what may have happened. Again, they will look at your cognitive and emotional evaluations. They'll look at your mental evaluation. Lots of genetic testing will be conducted. And of course, because this is a neurological disorder, you'll have CTs, MRIs, and PET scans. And of course, they'll do some serum blood testing. Unfortunately, there is no cure, but they will give you psychiatric drugs to help with the cognitive and the emotional issues. And then they'll give you drugs for dyskinesia to help with the muscle spasms and things that happen associated with that. The supportive care is normally with physical therapy, speech therapy. Of course, you have to manage your nutrition, and there is occupational therapy as well. Okay, so here we have sickle cell disease, and this is considered a single gene mutation with autosomal recessive inheritance. So both parents have to have the trait, and normally you have to have a homozygous disease phenotype. And when we talk about phenotype, that's the expression of the gene. Um, and you have a heterozygous carrier. As far as your mutation, the hemoglobin in the red blood cells are sickle shaped. These sickle shaped cells are known as hemoglobin S. As far as your clinical manifestations, you have jaundice, anemia, pain, organ damage, infection, and as far as your sickled cells, you have a high amount of sickling cells within the body at the time that you're having these manifestations. As far as your diagnostic criteria, it depends on your genetics. They'll look at your laboratory analysis, particularly the hemoglobin electrophoresis. They'll determine the amount of your hemoglobin types and their proportions compared to one another. They'll look at your complete blood count to determine if you have anemia. They'll look at your urine analysis, and they'll also test your liver and kidney function because these are the main organs that are damaged due to sickling of the cells. As far as treatment, it is symptom specific. More oftentimes than not, you're doing pain management and fluid replacement. You want to prevent infection in these individuals, so you'll often see antibiotics prescribed to them. You want to avoid temperature extremes to being too hot or being too cold. You want to reduce emotional and physical stress for these individuals, and you also want to promote the production of red blood cells with the hemoglobin F, and again, you want to treat the pain and the infection. So here we have Down syndrome, and this is an alteration in autosome numbers. So this is considered a trisomy, or 3 copies of the chromosome, particularly chromosome 21. And it is also the result of inherited translocation or non-disjuncture. So as far as Down syndrome, there is a mental delay. As far as clinical manifestations, you do have cardiac defects, gastrointestinal defects, visual and hearing impairment. There's a lot of thyroid dysfunction, and it could also present itself with leukemia. And you will often see facial features that are not normal with Down syndrome. As far as diagnostic criteria, of course, there has to be a history and physical examination. Normally, you can assess for trisomy on chromosome 21 in the prenatal phase. So you can have blood tests drawn or your amniocentesis that would pull your blood, and it would show if you have a high risk for Down syndrome. As far as other tests, you have a quadruple test. They will look at anatomic anomalies, which is just dysfunctions or not normal symptoms presented with the patient, and fetal karyotypes. As far as the treatment is concerned, you want to do the promotion of maximal independence and quality of life. You want to treat symptoms as they come. You want to have early intervention with therapies, speech therapy, occupational therapy, and physical therapy. And you also want to treat the associated congenital disorders. Again, this can present in tandem with leukemia. So now we'll talk about Turner syndrome. And the pathophysiology is an alteration in the sex chromosome number. So we're specifically talking about the sex chromosomes. And what it presents as is monosomy of chromosome X. So you only have one. And more frequently than not, it results in decreased life expectancy, diabetes, and heart disease. As far as clinical manifestations, the individuals normally have short stature. There is gonadal failure, so you'll see delayed puberty. Again, this is with the sex chromosomes, so there's a puberty issue. There's an infertility issue. There is cardiac and kidney abnormalities. The skeletal system is abnormal. You have soft tissue abnormalities. They present with hearing loss, and there are some learning difficulties or cognitive difficulties, as well as social problems. As far as your diagnostics, you have history and physical examination. We find out normally about this early with amniocentesis or prenatal blood screen tests. You have a edema. you have short femurs, you have a narrow aortic arch in the heart, and we also look at karyotype and genetic testing overall. As far as your treatment, it is the specific, and you want to really focus on that socialization aspect with individuals with Turner syndrome. And then there is hormonal therapy. Again, there is one chromosome X when there's supposed to be two pairs to help determine the sex. Now, you could still be male or female with this. This is not saying that you're not a male or not a female, but as far as your genetic makeup, you only have one when it's supposed to be two chromosomes for X. So this is Fragile X syndrome, and this is also a sex-linked issue. Similar to Turner syndrome, there is a defect on chromosome X, but this is actually a defect. It doesn't have to do with monosomy, so that is one of the distinctive differences between Fragile X and Turner syndrome. Fragile X is not dealing with a monosomy of the chromosome. It's just a defect on the chromosome that is associated with sex, more particularly the chromosome X. So it does cause mental retardation, and it normally affects males, but females can be carriers of Fragile X syndrome. So the clinical manifestations involve distinctive facial features. There is connective tissue abnormalities. They present with below average height. They are short. And even your testicles in the males, they are enlarged. So it's macroorchidism. The cognitive impairment and behavioral difficulties are still there. As far as your diagnostic criteria, you have history and physical examination, genetic screenings, prenatal screenings. As far as treatment, again, you want to focus on the behavioral and educational management. You want to help with socialization with individuals with Fragile X, and you also want to use some psychiatric drugs to help manage mental status and behavior. Now we'll talk about neural tube defects, and this is generally a defect that happens during the development of a fetus, or it's called embryologic development. So it does affect the nervous system, and particularly the tissues that are in development in this embryonic stage. And some of the manifestations that we see is spina bifida or ancephaly. So spina bifida is generally the incomplete closure of the vertebrae, whereas ancephaly is incomplete closure of the skull. Regardless, both of these areas would cause neural defects because that is a part of the central nervous system of a developing fetus. So as far as spina bifida, you have several types. You have spina bifida occulta, where your meninges aren't protruding, or you have the spinal cord not protruding. You have meningocoeli, where there is protrusion of the meninges. And then you have myomeningeocele, where there is protrusion of the meninges and the spinal cord and the nerve roots. As far as encephaly, again, that is just the incomplete closure of the skull, and you do see exposure of the brain and meninges. So as far as diagnostic criteria are concerned, there's a history and physical examination, and you normally have a prenatal screening. You can have an amniocentesis. There's ultrasound that can verify if it's present or not. And then you can have your serum alpha-fetoprotein levels that will also support. As far as your treatment, for ancephaly, you do supportive care. And then for spina bifida, there is surgical correction and also supportive care. So it just depends on the nature and the severity of what's going on for them to decide for surgical correction.